Hi guys, welcome back to week 6, or actually this is week 7. This week we are going to do a total content review of the last 6 weeks, modules 1 through 6, because as you guys know, this week is midterm time. So in this PowerPoint, I have quite a few slides, almost 90 slides, and it's just basic content review from the last 6 modules. And it's a lot of the same slides that you've already seen, but I handpicked certain things from each PowerPoint from each week that I specifically wanted you to focus on or that I felt we needed review. As you will see within Module 7, I've uploaded your midterm outline study guide. So please use that study guide and create your own study guide from that outline. It will really help guide you on this exam. And I would suggest that during this review, during this PowerPoint, you not only have the study guide in front of you, but you also have your textbook in front of you, your primary care textbook, 5th edition by Dumpy, because we are going to review quite a few of the questions from the last few quizzes. I handpicked specific questions that the majority of you actually either got wrong or I felt we should just review, because I don't think it's that you guys don't know the content. I think you're not reading the questions. So I just wanted to go through the quiz questions to point out that a lot of these questions that you guys are getting on the quizzes are actually straight content questions. They are knowledge check questions that are actually directly pulled from your book, meaning, I'm going to give you the page number and exactly where to look to see the exact, terminology specific to these quiz questions. So I'll go through that. I do want to make a point that it is your responsibility to complete the readings that are listed within the modules. What I am finding in a lot of the quizzes is that 2 things. Either number 1, you guys are not actually doing the readings or thoroughly reading, or number 2, you guys are doing the readings, but unfortunately, you're not retaining the information. And that's the most important thing. Hopefully you're gonna go through this and start to realize, where it is that you're missing key points, whether it's you're not looking at certain tables or you're not actually critiquing them carefully enough to make sure you're actually going to be able to remember a lot of that information. It's important to remember certain bits of information, like almost to the point of memorizing it, not because you're going to just need to know it for your midterm or your boards, but you're going to need this information at the tip of your tongue when you are in practice. When you have your patient presenting to you, especially in a crisis situation, most of this knowledge you need to know immediately. It's not like you're going to have time to be looking things up. There is certain information you have to know. So these quizzes are ways for you to review the content that you're reading in your textbook and making sure you're actually retaining it. So here we go, guys. So like I said, before you go through this PowerPoint, I would suggest you have your exam study guide printed in front of you, the actual outline, as well as your textbook, because I'd like for you to be able to go through your textbook as we're looking at these quiz questions, so you can really see where this information is coming from. All right, so let's go through these slides quickly. So again, we're reviewing Module 1. We're talking about evidence-based practice, ethical principles. Please, in terms of ethical and legal issues, there are 6 questions on your exam in this area. It's really important you know these specific ethical principles and how to apply them in terms of examples. You definitely want to make sure you review your steps to professional licensure, what it entails in terms of, what comes next step by step in terms of applying for certification, passing your exam, applying for, your state NP license. Those are the kinds of things you need to know and be aware of in terms of who is in charge of your licensure, which practice act, what is the purpose of the Nurse Practice Act. These are things you need to make sure you review. Here's your state licensure websites. These are just your professional licensure websites that you will need to know in the future. Those are within your module. So those are important for you to know how to access and where to access, because you're going to need those pretty much consistently throughout your career. Okay, so we will get into medical billing and coding in the exam. There are 10 questions, very, very similar to your quiz. You did the review quiz for coding and billing separate, so I won't get into that here. I am going to go ahead and post that review as well within Module 7, just so it's all condensed in terms of your ability to access different things to review. Again, if you're not understanding that, please go back into that module and look at the tutorial video that we uploaded from YouTube with the teaching tool. On your quiz, you will have your teaching tool guidelines with the questions, in particular these cards, which I actually find more helpful than the tool in your book, but they're the same information. This is just nice because it does, give you the HPI and the ROS elements. So you remember to differentiate between new versus established patients. Okay, there are going to be questions making sure you're able to differentiate the codes themselves. That's going to actually be a little different on your exam versus what was on your quiz. I am going to take it up a notch in terms of really making sure you're establishing whether it's a new patient code versus a established patient code. So let's say we ask you for a level 2 established, you may see a level 2 patient, new patient code, as well as a level 2 established code. Make sure you're differentiating those codes. And why is this important? Because let me tell you, one of the biggest audits you see in the coding is not only that you're not scoring high enough in terms of your level 3, level 4 with the acuity of your patient, but you're actually scoring the wrong code. And it's not even because you don't know. It's very easy to establish whether it's a new patient or an established patient. It's just a simple mistake. You accidentally put in 99211 as opposed to 99201. Because new patient level 1 would be a 99201 versus an established patient level 1 would be a 99211. So a simple mistake, but a big deal, and it will cause rejection. So that's why I am putting that on the quiz in terms of just making sure you're paying attention to those codes. Module 3, we did get into, actually, let me go back to coding, I'm sorry. So those are the big things. The other big thing in terms of medical billing and coding, I want to make sure that you are able to differentiate your HPI elements versus your review of system elements. A lot of you got that wrong, and it's simply because you probably just didn't read the question clearly. Just make sure you're slowly reading that question, guys, okay? I do feel a lot of the times some of these questions you guys are getting wrong. It's not because you don't know the information, it's just because you're not really reading the question right. So we'll go through some of these questions where I can give you some kind of test taking just tips in terms of how to read questions, because sometimes you'll be reading questions and you may not know the answer. You don't have any idea, you missed that reading, but you could still decipher information from the question in order to answer it correctly. So just make sure you're able to differentiate HPI elements versus review of system elements. You are going to be asked to fill in examples just like you were on your quiz, but keep in mind your examples are short and sweet. You don't have to create a whole, scenario of a patient. Just try to keep it very clear and simple. If we're asking for, a review of systems, 3 different review of systems, just do 3, bam, bam, bam. Ears, nose, throat, cardiovascular, chest pain, cough. For respiratory, like a cough, productive cough, keep it simple. I don't want you to waste time that you're going to need to be using towards reading other questions and answering them. All right, so again, medical billing and coding, you have about 10 questions. Review your medical billing quiz review, which again, I'll put that in the module so you have that quick access to it. So make sure you're looking at renal, your module 3, module 4 renal, you had part 1, part 2. Again, you are responsible to know the content in these readings. You can't just rely on one specific thing, but you do need to make sure you're doing your readings. So renal, the renal section of the exam will have 13 questions. Couple of things we need to make sure we are very clear on. You want to make sure you're doing your anatomy review and really conscious of normal findings and function of your renal system. So remember, it's important to know the normal findings so you know how to differentiate it from abnormal findings. You want to make sure you're reviewing common urinary complaints and causes, dysuria, hematuria, and acute urinary retention, as well as incontinence. Very important. I need you to make sure you can differentiate the different types of urinary incontinence, their clinical presentation, and the causes of. And how do we treat it? What are we doing? Bladder training. Remember, we talked about Kegel exercises. We talked about actual Kegel weights. So these are all different methodologies that you need to know so you can educate your patient on. So you definitely want to make sure you're reviewing the urinary tract infections, both lower UTI and upper UTIs, okay? Really important, know your risk factors for cystitis versus pyelonephritis. The one risk factor that's actually not listed in this diagram is pregnancy. That's a big risk factor for pyelonephritis. Remember, you know, a lower UTI can get very bad very quickly in a patient who's pregnant because that baby is pushing on the bladder. So it makes it even more susceptible to getting UTIs and then getting even worse, an upper UTI. Remember, pyelonephritis is something we really want to avoid. And it's very, very serious in that you need to make sure you're screening those patients that have pyelonephritis for risk factors as well as comorbidities that would put them at higher risk for sepsis. So these particular patients, we really need to screen carefully if they need to be hospitalized. A lot of them do. A lot of them do need to be hospitalized. So please put that on your radar. Okay, so here's a review question from the quiz. A patient is seen with a sudden onset of flank pain accompanied by nausea, vomiting, and diaphoresis. In addition to nephrolithiasis, which of the following should be added to the list of differential diagnoses? Okay, so a lot of you got this wrong. A lot of you picked urinary tract infection. So I want you to really, before you even think about this information too much in terms of pancreatitis versus a UTI versus a prostate cancer, you know, you're looking at those differentials and thinking about how each one presents, right? When we're looking at this question, there's a couple of keywords you need to pay attention to. Sudden onset of flank pain accompanied by nausea, vomiting, and diaphoresis. Okay, guys, so nausea, vomiting, and diaphoresis, that's severe. When you're thinking of those symptoms, especially sudden onset flank pain, that's not usually what we're seeing in a UTI. That's much more severe than a UTI. And the likelihood is if we're also already diagnosed with nephrolithiasis, we've already been screened for a UTI. So when we're thinking sudden nausea, vomiting, diaphoresis, that's sick, that's severe, and it's sudden. So we're probably thinking more in terms of pancreatitis, right? Because a prostate tumor, there's nothing really sudden about that. The symptoms come on pretty gradually, okay? GERD, none of that applies in terms of the severity of what's going on. And GERD really doesn't have a whole lot to do with nephrolithiasis. So again, look at those questions. Even if you don't really know the content answer itself, you can kind of decipher. Like a UTI, I would never think, oh, nausea, vomiting, and diaphoresis. That sounds pretty severe. You know, if I'm hearing nausea, vomiting, and diaphoresis in a company with a UTI, then I'm looking more towards pyelonephritis. Okay, so if we're looking at what's the most two severe, you know, or what are the two answers that I would look at? Because, you know, when you look at your 4 options of answers, you want to break it down. Okay, 2 of them I can get rid of right away. Prostate tumor is slow. There's no vomiting, diaphoresis, nausea. That's not accompanied with prostate tumors. GERD, same thing. I mean, there can be vomiting, but usually, you know, GERD is not a sudden onset of flank pain. So those 2 things I can rule out immediately. Those aren't the answers. UTI, you know, you don't see nausea, vomiting, and diaphoresis with a sudden onset. Usually it's a little more gradual, and, you know, those symptoms come later on as the infection gets worse and is left untreated. Then we come to pancreatitis. Okay, remember titus, the word, the ending of this word titus, that's inflammation, that's infection, that's something that's inflammatory, and usually anything that's inflammatory can come on sudden. So right there, I would kind of be leaning towards pancreatitis, even if I didn't know the symptoms associated with pancreatitis. All right, guys. So just again, consider test taking techniques as something to think about when you're going into a quiz or an exam. All right, and you know, try to take deep breaths. Don't freak out. I mean, there's ways. Again, even if you don't know the content, there are ways to read the question, look for keywords, and look also at your answers. Are there patterns in your answers? Are there things that are very, very obvious that are not the correct answer? So you can immediately cross those out and you narrow things down. Okay. All right, let's keep going. So another question, which of the following are predisposing factors for pyelonephritis? Okay, so pyelonephritis, what is pyelonephritis? So we know that is an upper UTI It's severe. It's something that we have to be concerned about in terms of hospitalizing patients, especially if they have other risk factors. When you look at these predisposing factors here, you know, what are predisposing factors that could make pyelonephritis something very severe? Well, again, let's knock out a few things. Alkaline urine, smoking, you know, those don't make anything better, but there certainly aren't predisposing factors that would make me concerned for a patient with, you know, with a UTI developing pyelonephritis. Dehydration, yeah, that's a little more concerning, but even more importantly, pregnancy. Pregnancy is a high risk, not comorbidity, but it's a high risk predisposing factor that you really need to be aware of with pyelonephritis. And in terms of, let's just go right back to this question with the pancreatitis. Again, this is more of a knowledge check question, just in general. So in terms of it being a knowledge check question, please look at your book, page 607. You're going to read under the clinical presentation of pancreatitis. So if you needed to review that, just go into your book, page 607, look at the clinical presentation of pancreatitis. Okay. Also, so for this, again, another, you know, in terms of predisposing factors for pyelonephritis, again, this is really a knowledge check question. Go ahead into your textbook, look at page 643, and under the pathophysiology of pyelonephritis, you know, you're going to read about your predisposing factors and, you know, how pregnancy makes you very high risk. Another side note that I want you to just be aware in terms of pyelonephritis, the majority of patients with pyelonephritis, like almost 95% of them, will respond to antibiotic treatment within 48 hours. So let me repeat that. When a patient is started on antibiotics for pyelonephritis, 95% of them, research shows that they will respond to the antibiotic treatment within 48 hours. So make sure you are conscious of that, educate your patients about that, because if they are not responding, then we may not have diagnosed correctly or have picked the wrong type of treatment. Okay, so here's your pancreatitis. A patient is seen, we went over this, page 607. Okay, which of the following medications will help reduce urinary excretion of nephrolithiasis forming substances? Okay, again, a knowledge check question. Look at page 648, your first paragraph. You know, when we're looking at these answers, furosemide, triamterene, those two right there in terms of knocking out 2 of the 4 answers, because we want to kind of narrow it down to 2 of our best options. But if we look at A and B, both of those medications, furosemide or Lasix, and triamterene, increase calciuria and typically actually worsen renal stone formation. You know, look at your question again. Which of the following medications will help reduce urinary excretion of nephrolithiasis forming substances? So the first thing you need to ask yourself is, what is nephrolithiasis forming substances? So all that means are stone forming substances. Which of these medications are going to cause your patient to create more stones? We don't want any more stones. So those are the 2 drugs, triamterene and furosemide, both, you know, increase the calciuria. I want you to look at page 648 just to review that. And of course, hydrochlorothiazide is actually the only medication there that can reduce the calcium excretion. Okay, so that's the correct answer. All right, make sure you're reviewing your labs related to the renal system, your serum creatinine clearance. You want to make sure you're understanding your eGFR, and you are looking at page 660 at table 45.1 to differentiate your stages of chronic kidney disease. Super important, guys. You want to make sure you can differentiate your chronic kidney disease, the stages based on your GFR. Okay, so make sure you're looking at that so you know how to differentiate. You also want to make sure you're able to differentiate your clinical presentation of chronic kidney disease. So what do those patients look like? You need to make sure you're able to look at that. Review your drugs commonly prescribed for UTIs. That's in your table 44.2 on page 639. You have your different classifications that you could prescribe, your cephalosporins. You want to know your urinary analgesics for patients who are you know, having pain associated with their UTIs. What are we prescribing? Pyridium, it's over the counter. And you want to actually keep in mind that if clinical symptoms of the UTI persist for 48 to 72 hours after initiating antibiotics. That's when you need to order a urine culture and sensitivity, as well as a UA, excuse me. And of course, just like I said before, especially if your patient has any comorbidities that would put them at high risk for pyelonephritis, you want to make sure you're ruling that out. Okay, so in your book, here's your page 660 table of your chronic kidney disease and your stages. And so you look at those numbers. When you're reading these tables, whether it's for this or any other table, like sometimes you're looking at this and you're like, okay, I'm looking at it and I'm reading it and I get it, but how do I remember all of this? So you're looking, let's look at our stages. First things first, how many stages do we have? We go from 1 to 5, okay? The first thing I wanna know is how is the world staging chronic kidney disease? Are we staging it 1 is worst or 5 is worst? So when we're staging chronic kidney disease, stage 5 is the worst. That means we're at the end. So we're end stage. So now we know the higher the number, the worse the disease, right? So that's, first of all, that's how we're gonna just keep it basic. Stage 1 is the least worrisome. Stage 5 is the worst. We're in trouble, right? The other big thing, how is our GFR in each stage? What are we looking at in terms of varying stages? So in the normal kidney function, we're at a greater than 90 mLs per minute, okay? The worst is we're at less than 15 mLs per minute, okay? So we go from 90 to 15, that's how bad our kidneys are. So 90 is great, 15 is not so good at all. 15 is the worst. So put it in perspective in terms of least to, or worst to least, or least to greatest, however you want to do it. But that way you can just kind of get a broad perspective of how you're going to remember this. Okay, I'm remembering stage 5 is the worst because 5 is, you know, the higher the number, the worse it is. And I also know at the worst stage, we're down to 15 mLs per minute. So when I know we're at 15 and we're at stage 5, we're at the end, right? And then what are my symptoms? So severe hypertension, anemia, uremia. And of course, at this point, we've already referred to a specialist and we're already in dialysis. Okay, so again, differentiate your stages and really try to pinpoint different factors that differentiates them. So you will actually retain this information and can apply it to these very basic knowledge check questions in your quizzes, okay, whether it's for this particular diagram or table or any other one. Now, again, your quizzes are really straight knowledge check questions. There's not a whole lot of, you know, critical thinking or rationales, a few of them, but not many. That's where your midterm comes in. So use these quizzes to review and learn your basic content and your knowledge, conceptual understanding of your knowledge from your textbook. And then, you know, once we get into the midterm, that's when you're going to get more critical thinking questions, as well as, of course, on your boards. So again, now the next thing we need to make sure you're reviewing is table 45.2 on your bladder tumor treatment and staging. Again, you're looking at these tables. How do I differentiate these stages? How am I going to remember this? Okay, so again, we're going from stage 2 to stage, this one is only going from stage 0 to stage 4. But again, we're going from 0 to 4 and I'm looking at my description. And of course, 0 is non-invasive versus stage 4 is the worst. Cancer has grown through the bladder wall. You know, so again, we're differentiating our stages from 0 to 4 and really pinpointing what are the differentiating factors within each stage so I know how to apply that to my critical thinking questions. So your danger signals, we talked about this, just make sure you're reviewing. These are things you need to make sure you know. They're almost like your clinical pearls. You know, again, these are things, yes, you do need to memorize. So you've got your bladder cancer. What are you ordering? You've got your acute kidney injury, acute renal failure, acute pyelonephritis, and rhabdomyolysis. These are the big things that you need to make sure you're ruling out. Another thing I wanted to point out in terms of answering questions on quizzes, exams, whatever, always consider when the question is asking you to consider a different differential or consider what is the highest, you know, you always want to lean towards your answer that is the highest priority diagnosis to rule out. Highest priority meaning cancer or something that is highly fatal, okay? Things that are highly fatal, like you want to rule out that it's, you know, the guy's not having an MI or an aortic aneurysm or, you know, anything that's severe that could lead to death. Those are things you want to rule out immediately just to make sure that that's not an issue and it's not something that you have to worry about and you're not going to be able to sleep at night as a practitioner because you're afraid your patient might die in their sleep. Those are the things you have to take care of because, you know, they are priority. So just keep that in mind. when you are looking at and answering questions, you know, the likelihood is they're asking you, what's the worst case scenario here, and how are you going to handle it? And here you have some pearls of wisdom in terms of these particular highly fatal type diagnoses. Okay, you want to know your stages of acute kidney injury. So here we're talking about stage 3, looking at your changes in serum creatinine levels, your urine output. Again, what is the differentiating here? Stages 1 to 3. So again, you know, try to differentiate what's different about each particular stage that sticks out to you the most, so you know how to apply this when it comes to looking at this information on a quiz. Okay. In terms of acute renal failure and acute kidney injury, we want to make sure we're looking at clinical manifestations, presentation, diagnostics, and just make sure that you also are conscientious of the differences in hematuria versus dysuria, and the causes of treatment for and the diagnostics. Okay, another question review. A patient is seen in the clinic and diagnosed with stage 1 renal cancer. The patient should refer the patient to a nephrologist for which of these treatments? Okay, again, knowledge check question. I want you to go ahead and look at page 664. You can see right there that it says very blatantly, they break down the stages, and stage 1 is consistently treated with a nephrectomy. Okay, so, and again, you know, let's say you didn't know this, you just missed this part of your readings, or you just forget and can't remember. Look at this question. Let's dissect this. Let's consider some test taking techniques with this question. A patient is seen in the clinic and diagnosed with stage 1 renal cancer. So the likelihood is, you know, in most staging of cancers, stage 1 is still pretty low, right? I mean, it's not perfect, but it's certainly not stage 3, 4, 5, right? So already we're on the lower end. So if we're on the lower end of staging, do we really already need to consider palliative treatment? Do we need to consider chemotherapy, radiation? I don't know, but here's another thing. When we're looking at these answers, you know, usually when it comes to chemo and radiation, they kind of go hand in hand. So I'm already going to say, I don't really think A or D is the right answer, because, you know, it most likely, like, they kind of are the same. C, I'm definitely going to throw out palliative treatment. I'm not already going to put a stage 1 cancer with palliative treatment. And so what's my last answer that's remaining? Nephrectomy. Okay. But again, you know, you do want to make sure you're aware of the different treatments with each stage. So look at page 664 and just make sure you're reviewing that. Okay, question review. Lakina has CKD, chronic kidney disease. Her GFR is 33 mLs per minute. And which of these stages does her GFR fall under as defined by the 3rd National Health and Nutrition Examination Survey? Again, knowledge check question, guys. Are you reading? And if you're not, if you are reading, why isn't this sticking? So again, let's go back to our textbook, page 660, right on table 45.1, we can differentiate the stages of CKD. Or even on page 659, instead of a table, if you don't like the table, 659 also does a very basic breakdown within the text. Okay, so you can look at that. But just keep in mind, in stage 3, you know, looking at those tables, how are we differentiating the stages? How are we making sure we've retained enough knowledge from that table to know what sticks out to me the most that would differentiate stage 1 from stage 3, or stage 3 from stage 4? And that the biggest thing is your GFR. GFR at stage 3 is between 30 and 44. Okay, that's already, we have entered renal insufficiency. So, you know, that's how you have to make sure you're reading those tables, making sure you're retaining that information that's going to differentiate stage 1 from stage 4. Okay. Again, that would be on page 660 of your book in table 45.1. Look at those tables, guys. They're not just there to look cute. Like, they are there because you need to know that information, and they are beautiful resources in terms of just summarizing the information and putting it in a way, again, that's going to help you be able to differentiate it in your brain and kind of try to retain the different stages and the different symptoms that present with each stage. Okay, question review. Danielle presents to the clinic saying, I do not feel like I want to eat. She also noticed she's experiencing lethargy, nausea, headache, and muscle cramps. She did not go to the bathroom a lot. yesterday, quote unquote, and which of the following stages of acute kidney injury is Danielle in? Okay, again, knowledge check question, guys. So look at page 653, the third paragraph down, and there they describe the 4 stages of AKI. Okay, and again, this is actually pretty basic. When you read it, you'll understand, and you're going to be like, oh my God, how did I get this wrong? But again, if you're not reading and retaining, you're not going to know this stuff. It's, sometimes you can decipher, but a lot of the times, if you don't have that basic knowledge base from your textbook and just making sure you're reading all this information and retaining it, it's going to be hard to answer these questions. But again, I'm going to just give you some clues here with this in terms of just basic test taking clues. So we're presenting to the clinic. The patient's telling you, I don't want to eat. I don't feel like I'm eating. I'm getting a little headache, nausea, a little lethargy. So I didn't go to the bathroom a lot yesterday. So this is, it sounds like a very new start of something. It sounds like a basic, symptoms, nothing drastic, nothing very intense yet. It's obviously something's brewing, but she's not in the midst of a crisis at this point. So for me, immediately, because it's all pretty kind of new and everything is just kind of starting, I would have immediately just said it's initiating, because initiating to me means starting, right? Like it's the beginning. I don't know anything else about this. Like, let's say I don't know anything else about the other stages, but I do know initiation sounds like the start of something, and what she's presenting with sounds like the start of something. So for me, if I didn't know the answer to this, I would have just picked A just because of the word initiate. So think in those terms if you don't know the actual answer to the question, guys. Okay. Question review. A 58-year-old African-American male presents to your private practice with complaints of new onset lower back pain and rectal pain accompanied by a weak urine stream and nocturia. The patient is morbidly obese and has a family history of cancer, including his father and brother. What diagnosis would you consider of highest priority to rule out based on the information above? So guys, this is pretty basic, but where I saw you guys, everybody had the right answer in terms of going in the right direction towards a differential diagnosis. But the key thing here that I need to point out to you and point out to you just in general, when you're looking at diagnoses of highest priority, guys. So again, those diagnoses that are deadly, those diagnoses that you're concerned that if they don't get treatment immediately, it's going to get ugly. Those diagnoses that are accompanied by patients who have comorbidities that are really going to put whatever diagnoses they're presenting with over the edge. So in particular for this patient, we're looking at what information led you to your diagnosis. Well, I've got quite a few factors here, risk factors for this guy. He's 58 years old. When we start getting into our upper 50s, early 60s, no matter what color, no matter what our health is, we're at risk. That is a risky age. Trust me when I tell you, I can't tell you how many patients who come in who've had nothing wrong with them. They're 58, 59, 60. When they hit that 60, boy, stuff just starts happening. It's crazy. It is a crazy thing, but it's the truth. So when you see 58, 59, 60, you always want to think, okay, age is a risk factor. He's African-American. We already know with African-Americans, there are certain predisposing things that are just higher risk, right? So, okay, so we have that under our belt. He's a male. He presents to our private practice with complaints of new onset lower back pain, rectal pain, weak urine stream, and nocturia. Boy, he has a lot of symptoms of quite a few different things I could pinpoint. But here's the key thing. This is it. Read this sentence. The patient is morbidly obese. So we're morbidly obese. We're African-American. We're at that age where we're concerned. And we have a family history of cancer in his father and brother. Now, it doesn't tell you what type of cancer, but already we know it's on the paternal side, father and brother. So right there, I would have immediately said, okay, I'm worried about cancer, specifically prostate, okay? Some of you put BPH, prostatitis, those are all definite differential factors, differential diagnoses that I would consider. But my highest priority with this guy, especially since his father and brother had cancer, and he's, got these symptoms, and he's African-American, and he's morbidly obese, no, we have to rule out prostate cancer immediately. Okay, guys? So, and these are just definitely things you need to consider in terms of highest priority. Make sure you're reading those questions, okay? All right, so more readings that you were assigned in terms of topics for discussion within Module 4. Make sure you have those readings done. And I only included the readings within this PowerPoint just to remind you, this is where all this information and all of your content is coming from. So hopefully you guys are really reading your books, okay? Super important. Okay. Make sure you'll, again, prostate cancer and knowing your differentials. Remember, most common cancer found in American men, all right? It's asymptomatic early in the disease. And then we get into our latent symptoms. That's when we know we're in trouble. Remember, anytime you're hearing about sudden weight loss, blood loss, bone pain, sudden new pain, these are all signs of cancer. We need to rule out cancer, all right? Whether it's prostate, and in particular, this is your latent symptoms in prostate, but really realistically, in any patient who's talking to you about sudden weight loss, sudden change in appetite, sudden blood loss, shortness of breath, a lot of fatigue, we need to rule out cancer, guys. Also, another thing, I think we discussed this before, but just as a reminder, clinical pearl, in terms of symptoms and signs of cancer, if a patient starts suddenly throwing blood clots, they start all of a sudden having lots of blood clots, we need to rule out cancer. That's a sign. All right, when it comes to signs and symptoms of prostatitis, we want to focus on our history so we can really differentiate which type of prostatitis we're dealing with. All right, so make sure you review those. Erectile dysfunction, epididymis, we talked about that. Testicular torsion, hydrocele, variocele, and testicular cancer. Make sure you're reviewing all of those things. Remember to review your transillumination. Sorry, I lost my study guide. Oh, here it is. Okay. Make sure you're reviewing transillumination, the diagnostics, and how it's done in terms of checking for a hydrocele. Okay. We talked about STIs, just in terms of epidemiology, risk factors, and differentiating that between that and just basic UTI prostatitis type infections. We got into our common endocrine and metabolic complaints. In terms of endocrine, there are 7 questions on the exam. You want to make sure that you know your treatment for diabetes type 2, your diagnostics, and your A1C. You want to make sure you know how to differentiate hypothyroidism, what your clinical manifestations are, and you're differentiating hypothyroidism versus hyperthyroidism. Here, make sure you're differentiating your differentials for polydipsia, polyphagia, and polyuria. This is a great tool. It's right from your textbook in terms of, figuring out your differentials and it's an algorithm that to use to figure out your differentials between the polydipsia, polyphagia, and polyuria. Most people immediately, they hear those 3 things and they just automatically think diabetes, but you do have other considerations to take into effect. For instance, polydipsia with head trauma, or polyphagia with anorexia. Okay, things to consider. Okay, you want to make sure you reviewed your glandular disorders in terms of hypothyroidism, thyroid cancer, hyperthyroidism. You want to review your adrenal insufficiency, Addison's versus hypercortisolism. We know we have to review diabetes, so type 1, type 2, and hypoglycemia. Metabolic disorders, you definitely want to make sure you are reviewing your obesity, being able to differentiate upper versus lower body obesity, or upper body also being central obesity. Remember, obesity is considered a BMI of 30 or more. You want to look at your obesity in your text and make sure you're differentiating between obesity versus morbid obesity, okay? And how you look at your BMI chart, or how you figure out your BMI so that you can differentiate that in your patients. You always want to try to include the BMI in all of your patients' physical assessments. Your BMI gives you a lot of information. It's one of the first things I look at when I look at a patient's chart. Make sure you're reviewing gout, your assessment, your treatment, your diagnostics, and what is our pain management for these patients. It's very painful. All right, we're getting into pulmonary now. So there are 14 questions on your exam on pulmonary. Lots of information. I put a lot of slides in here just with diagrams, but let's just go ahead and go focus through. So we're looking at our different types of pneumonia, bacterial versus viral pneumonia. You want to make sure you're able to differentiate how the clinical presentation of both. Remember, your bacterial pneumonia or atypical is rapid versus your viral, which can be slow and insidious. You want to review your common respiratory complaints, including coughs, the different reasons for cough, the different differentials for coughs, and keep in mind, you want to review your medications that could possibly be causing coughs, including your ACE inhibitors and your ARBs. You want to make sure you are very, very clear on acute epiglottitis, very, very serious, life-threatening. Very important that you really review this. I want you to look at page 372 in box 31 for your clinical manifestations, your diagnostic reasoning, and your management of acute epiglottitis. Okay, there is a question on the exam on this. Please know this. It's very important. We want to be able to differentiate a cold versus a flu. Know your signs and symptoms. Remember, your CDC guidelines are really important in differentiating this specifically to the season. So make sure you're updated in your practice to what the current CDC guidelines are, to what the current bugs are out there in that particular season. I already went through this, but again, bacterial versus viral pneumonia. You want to know your top two community-acquired bacteria pneumonia. So remember, your CAP pneumonia is your community-acquired pneumonia versus your atypical pneumonia, also known as walking pneumonia. And I always remember walking and atypical pneumonia is your bacterial pneumonia, and it's insidious. Okay, guys? And remember little hints. So if you're hearing a question about rust-colored or blood-tinged sputum, the likelihood is it's S. pneumoniae. It's caused by this type, S. pneumoniae. Versus COPD smoker with pneumonia, they most likely have H. influenza bacteria. So you need to be able to differentiate your bacteria, especially considering, considering the differentials of your patient when it comes to their comorbidities. Because certain people, certain type of diagnoses are more prone to certain bacteria than others. We need to make sure we're reviewing our tuberculosis. We need to know our risk factors. We need to know our treatment. Remember, you are a mandated reporter. So the health department is always involved in cases with TB because it is so contagious, and we need to make sure these patients are taking their drugs because we have such an issue in the world with multi-drug resistant TB. We have to be on top of this in order to keep that under control. You want to make sure you're understanding your interpretation of TB skin testing, all right? Make sure you're looking in your textbook at page 388, table 30.2, to really interpret your TB skin testing. So keep in mind, you want to understand the risk factors that would indicate a positive result, as well as the diameter of the induration. So the diameter of the induration can vary in terms of what's going to be positive based on comorbidities or risk factors that your patients have. So things like being, actually, let's look at that together. So it's on page 388. So things, so positive results in terms of your diameter of induration, it's positive if it's 15 or greater, but only if they don't have other factors. So if the patient has HIV, if they're HIV positive, if the patient was recently exposed to a clinically active patient with TB, like let's say they had exposure to somebody with active TB, or they had a chest x-ray indicating that they had TB in the past, that changes when they are positive in terms of their induration. So they need something at 5 mm's with these to be a positive result. All right, so make sure you're differentiating when they would be considered positive based on their other risk factors. Okay, so asthma, definitely need to get into asthma. You want to make sure you know your principal triggers. You want to make sure you understand your presentation, the classification of asthma severity. So that is in your book, again, page 400 and 401. Look at table 31.1. Here we're going to find management, risk factors for exacerbation, patient education, and GINA treatment guidelines. Make sure you're reviewing the GINA treatment guidelines. So in your pulmonary module, you have tons of information from different organizations for your gold standards of care for both COPD and asthma, please make sure you're reviewing that. You need to know it. Okay. Chronic bronchitis and emphysema, also known as COPD. Remember, your umbrella term, chronic obstructive pulmonary disease, encompasses chronic bronchitis and emphysema. Here we have to make sure we're differentiating between restrictive versus obstructive respiratory disorders. We went over this. There is a table in here that I'll show you. I think it's further in the slide, so I'll show you that when we get to it. But just make sure you're reviewing your COPD, chronic bronchitis, and emphysema. Make sure that you look at page 409 for page 409, table 31.3, okay? And page 412 as well, because that's talking about your treatment standards and guidelines on page 412 for COPD. Okay, question review. Sam, age 78, presents to the clinic with respiratory symptoms. His pulmonary function tests are as follows. He has a normal total lung capacity, a decreased PO2, an increased PaCO2. On assessment, you auscultate coarse crackles and forced expiratory wheezes. What is your diagnosis? So a lot of you, this was kind of a tricky one, but again, this is a knowledge check. The correct answer is chronic bronchitis, okay? So what is the differentiating thing here in this question that would actually pinpoint it was chronic bronchitis? So how do we know? Okay, the thing we're looking at here, that if you don't know, this is where you need to go back to your table, 31.2 on page 409, okay? Again, look in your textbook, page 409, table 31.2, and on that table, you're gonna see pulmonary function and physical findings in obstructive and restrictive lung diseases. Here in this table, it differentiates how each of these particular diagnoses are different, because they all have a lot of similarities, but there are a few differentiating factors that really will help you differentiate it. And in this question, the one thing you needed to make sure you looked at was an increased PaCO2. Right there, that differentiates chronic bronchitis from the other three diagnoses. So again, look at your table and notice under chronic bronchitis, it's the only disease listed in that table with a consistent increased PaCO2 consistently throughout the clinical manifestations. The other ones, they kind of become insidious and increase later on, but chronic bronchitis is consistently has an increased PaCO2. So that's how you got to differentiate it. Again, it was a knowledge check question. Review your tables, guys, page 409, 31.2. Look at those tables, figure out how to differentiate things so that those key things will pop up in your brain so that you know how to differentiate it on these types of questions. This was more of a critical thinking type question as well as a knowledge check, okay? Now, again, if you wanted to do it from just looking at it from a basic test taking review type question, so look at this question in terms of your answers. Influenza, right there, we can cut that off. Like, we know that has nothing to do with this, especially in terms of what the quiz is about. You know, we're quizzing on respiratory disorders. Influenza is influenza. It's not a particular specific respiratory diagnosis. So right there, we can block out influenza. All right, so we have 3 responses left. We have A, asthma, B, emphysema, and C, chronic bronchitis, okay? So this is a little more tricky because now you really had to know which one of these has a decreased PaO2, which one would have an increased PaCO2, and which one would you auscultate coarse crackles and forced expiratory wheezes. That gives you a lot of information, but again, your increased PaCO2 is probably your key thing here to differentiate your emphysema from your chronic bronchitis. All right, I'm going to quickly go through this. Again, question review, knowledge check. We just talked about this. It's in your book on that table. 30.2, interpretation of TB skin testing. Okay, make sure you're looking at that table. You also want to make sure to review those risk factors contributing to a decreased response to TB skin testing. Okay, we want to review interstitial lung disease, lung cancer. Make sure you know the different stages and you know what the basic treatments are in terms of that. Again, your smoking cessation, that's so huge. You definitely had questions on it. Let's review those real quick. So Nathan, a 32-year-old policeman, has a 15-year pack history of smoking and continue to smoke heavily. During every visit, he gets irate when you try to talk to him about quitting. What should you do? Okay, so I know this was a little tricky, but again, this was a knowledge check question. If you had read you need to make sure you read that article that was uploaded into your module on the USPSTF recommendations regarding smoking cessation. So important. Most of the questions actually came right from that article. Again, really straight knowledge base. This isn't not a tricky question. So the bottom line is CDC guidelines, you ask at every single visit whether they want to hear it or not. Because guess what, guys, you are their practitioner. It is your responsibility to make sure that every time they come to visit, you are reinforcing with them that it is important that they prepare to quit or discuss quitting or consider quitting or think about quitting, because really smoking is that serious and it will kill him. Okay, it's going to make his life horrible. And you as a practitioner have an ethical responsibility to consistently bring it up, even if they don't like it. Too bad, because guess what? When they get cancer or when they have to change their entire life because they get sick, because of all the risk factors that come with cancer and smoking, their life is going to be, they're going to be a lot more upset than they are just at you for asking them if they're ready to quit. So that's what you need to do. Every visit, you're asking him gently. You're not, being demanding or anything of that nature. You're just kind of bringing it up. How's it going? Have you cut back at all? Are you ready to quit yet? Are you ready to talk about some ways we can start getting you off of these cigarettes? Whatever it is, you're gentle, but you're always talking about it and bringing it up. Because if you don't, who will, right? Nobody else is going to do it. And that is your role as their practitioner, is to bring them the best options available, hopefully. It's also about primary prevention. We talked about that in FNP 1. So remember, smoking cessation is considered primary prevention. In terms of looking at these answers and trying to kind of narrowing it down if you weren't sure. So in terms of handing him literature about smoking cessation at every visit, that's a waste. Don't bother doing that unless he's asking for it or wants it. B, wait until he's ready to talk to you about quitting. Don't wait. Waiting is bad. Waiting is bad. Why is waiting bad? Because he's just continuing to smoke, and guess what? Nothing's getting better. C, document in the record that he is not ready to quit. Well, if you don't know he's ready to quit because you didn't ask him, how are you supposed to document that? From one visit to the next, you're always doing a review of systems and an HPI. You're not assuming that your review of systems from one visit to the next is the same, right? So you can't assume that with smoking as well. You have to make sure you're asking at every visit where they're at with that, because you never know. From one visit to the next, something may have changed or triggered him in his life that now suddenly he is more open to quitting. Okay, which of these sputum stains would one use to test for a viral respiratory culture? Again, guys, this is a knowledge check. Page 381, table 30.1. You want to look at your advanced assessment sputum staining table. It's right there, very, very clear. Your direct fluorescent antibody stain is specific to a viral respiratory culture. So again, just look at page 381. Make sure you're reviewing those tables to get a clear understanding of what particular stain goes with which particular culture. Okay, question review. According to the USPSTF recommendations, all patients should be asked about their tobacco use. Common approaches for clinicians to assess patients' tobacco use includes the following. All of the above, guys, every single one of them, okay? Again, knowledge check, that was specific right from that article that I uploaded into the module. It's so important, all of these things that you do. I love, actually, C is one of my favorite things, the vital sign. I think that's a fantastic idea because really you're recording, where the patient is at. It's holding you liable, just like you would check their blood pressure, check their pain levels. If you include smoking status as a vital sign at every visit, what a great way to monitor where the patient is at. I mean, smoking status doesn't have to just necessarily mean, are they ready to quit? Smoking status could be from one visit to the next, they went from smoking a pack and a half to smoking half a pack. That's a good smoking status. That means we are decreasing our smoking and we're on a good path towards hopefully smoking cessation. So, but the reality of it is, in terms of the recommendations, every single one of those answers is correct. So all of the above. Make sure you read that article, guys. This next question also came from that article, same thing. Again, I think you guys just didn't really read the answers, quite clearly, because a lot of you actually got this right, but I could see where it was you got it wrong just in terms of not reading the answers thoroughly. So the correct answer, number one, is that there is not current evidence is insufficient. There is not enough evidence to show the balance of benefits and harm of e-cigarettes for tobacco cessation in adults, including pregnant persons. Okay, so the key here is make sure you included that it's insufficient. There is not enough evidence. Again, this was right in the article, and it's both for adults, including pregnant persons. Okay, and this actually makes sense if you think about it, because how are they going to have enough sufficient evidence regarding harms and benefits of e-cigarettes in pregnant people? Who's going to test that on those people, right? Who's going to run that study? Nobody's going to participate in that. That's not a real thing. So how could they even have enough evidence?
It's 7 o'clock.
Okay, pulmonary function test, make sure you're reviewing that. Here is your chart in terms of reviewing the differences between obstructive versus restrictive disorders. Make sure you're conscientious of what falls under obstructive. We have COPD, asthma, bronchiectasis versus restrictive, which is marked obesity, interstitial lung disease, and scoliosis. Again, this is in terms of your pulmonary function and your type of restrictive versus obstructive, and how it correlates with your FEV1 and FVC, and it also differentiates your causes. So make sure you're reviewing this, guys. Okay, X-ray interpretation. We talked about this. There's quite a few videos I asked you to watch. Again, just the biggest thing with X-ray interpretation is understanding it's a systematic process. And you need to know your landmarks, and you need to know what looks normal. So make sure you're reviewing these normal images of your X-ray, so that when you look at an abnormal X-ray and you don't see landmarks, or things are out of proportion as to where they should be, you know what you're looking at and why it's in the wrong place. Again, make sure you're looking at your USPSTF recommendations, specifically for tobacco use, but I added this little table just to remind you there are recommendations for practice implementation for all types of different things: blood pressure, blood glucose, breast cancer screening, depression screening. So these are recommendations, and they are guidelines for us as practitioners. So you need to make sure you are following them and you are aware of them, okay? But specifically in this particular table, it's more about tobacco use. Know your stages of COPD. Remember, look at your numbers in terms of differentiating mild versus chronic. So 80% is mild in terms of that's normal airways for your stages of COPD, versus chronic is greater than 30%. Okay. So in terms of asthma, we're assessing severity first to determine our initial treatment. So make sure you're looking in your textbook. They have some great algorithms for managing asthma. I love their algorithms, specifically this one. This is on table 31.1 on page 401. Really, really good table. It gives you exactly what you need to know in terms of how you treat, okay? So you're going from your step 1, steps 2, and where do you start with inhalers, right? What are you starting with? So this is a great table, excuse me, to give you, your guidelines in terms of treating. And down here in the left corner, it gives you your little, it defines the acronyms here. So this gets confusing sometimes. So this is a great table because you can see SABA versus ALABA and how they break it down. Here's your guidelines for pneumonia. Make sure you're looking at your CAP guidelines and what criteria would indicate that they need to be hospitalized. Okay, so that there is the CURB tool. Make sure you're reviewing that. Where was this? Let me just see something. But yeah, it's your CURB 65 tool. It's on page 388. 383, I'm sorry. And it's a tool for scoring severity of community-acquired pneumonia and risk factors that would increase mortality and complications, so you know when you need to hospitalize your patients. And here is your community-acquired pneumonia diagnosis in terms of what you're going to be ordering and what you want to do in terms of either hospitalization or not, depending on the severity and the disposition of the patient. Here's that curve 65 severity scoring. And this is what gives you how they, come up with the numbers to decide whether or not patient is low risk versus they need to be put in the ICU. Here is your tuberculosis measurements. Again, this is in your book in that chart that I mentioned before on page 388 in terms of understanding, and interpreting your TB skin testing. So these are the risk factors that are also included in terms of diagnosing for a positive skin TB test. We want to make sure you review obstructive sleep apnea. We have normal breathing versus snoring versus OSA. So just make sure you're reviewing clinical presentation, risk factors, and treatment. Question, which of the following scales is useful to assess the degree of dyspnea with a score of 6 to 20? Again, this was a knowledge check question. And this is found in your book on page 360 in the second or third paragraph down. It describes the Borg scale. Okay, the Borg scale is what we use to assess the degree of dyspnea. All right, next. African-American patients seem to have a negative reaction to which of the following asthma medications? Now, a lot of you, actually most of you wrote C, leukotriene receptor agonists. But again, this was a knowledge check. I'm actually going to take 2 answers for this because you all got the same question, answered the same one, but the actual answer is B. So recent genetic and epidemiological studies have shown that long-term beta agonists, bronchodilators, such as Advair, that's one in particular, actually African-Americans do not respond well to. So if you needed to read on that, please see your textbook, page 402. They talk about those studies, all right? Correct answer is B. Okay, your patient has decided to try to quit smoking with Chantix. You're discussing his quit date and he will begin taking the medicine tomorrow. When should he plan to quit smoking? So again, this was a knowledge check question, but at the same time, this is a question that we can definitely decipher if we still didn't know the answer to it. So the bottom line is the answer is his quit date should be in 1 week, which is the basic recommendation for Chantix. Again, it's a knowledge check question. Read your book, page 445. It's up top on the first paragraph, all right, page 445. But when you're looking at this question, just in terms of thinking about somebody quitting smoking, okay, A, he should stop smoking today. Okay, is that realistic? Does any drug work quickly enough that he should just suddenly stop working today? That's not very realistic. I would never tell somebody who's trying to quit smoking to just go cold turkey if that's not something they were open to begin with, right? Especially if they're trying with a medication. So A, we're going to throw out right away. B, he should stop smoking tomorrow. Also not realistic. So again, A and B we can throw out immediately. Now we have 2 answers left to choose from. He will be ready to quit after the first 30 days. Or C, his quit date should be in 1 week. Now, me personally, if I didn't know the answer to this, I probably would have chose D. Because that probably would be the next best answer. But realistically with Chantix, the benefit of it is you can quit within you should be able to quit in 1 week. So that's the guideline with Chantix. It's a knowledge check question. But again, try to narrow down your answers to 2 best answers for the particular question, guys. All right. Okay, Sydney presents with a history of asthma. She has not been treated for a while. She complains of daily but not continual symptoms greater than 1 week and at nighttime. She has been using her rescue inhaler. Her FEV1 is 60 to 80% predicted. How would you classify her asthma severity? Okay, again, knowledge check question. Let's look at page 400 in table 31.1. And here you're going to see a nice, beautiful table of your classification of asthma severity. And this is how you break it down. Again, look at these tables, differentiate your levels so you can figure out how to look at questions like this and say, okay, I know what's consistent here for this particular thing. That's how I know it's this, right? So look at table 31.1. And the bottom line is, in terms of it being moderate persistent, the FEV1 for moderate persistent is listed between 60 to 80. So right there, your FEV1 that they provided you gave you the right answer. However, if you didn't know what the FEV1 for moderate persistent is, let's look at this question and see if we can kind of figure it out, like just from a basic standpoint. So she's got asthma, so we know that. She has not been treated for a while, okay. She complains of daily but not continual symptoms. All right, daily, right there, I already know we can knock out A, because if it's daily, it's not intermittent, it's persistent, right? Because it's every day. So that right now we know it's persistent. So that leaves me with 3 answers. So it's daily, but it's not continual, and it's greater than 1 week at a time. So if it's daily but not continual, it doesn't sound like it's so severe, so we can knock out D. So all we have left is mild or moderate persistent. So we have B and C left. I'm gonna go more with moderate, because she says it's daily, but it's not continual, but it is greater than 1 week and at nighttime. So I kind of would have just logically guessed this is a moderate level. Now, more importantly, is it persistent or intermittent? And we already know it's persistent because it's every single day. Okay, so that's just a way of deciphering that question without actually knowing the FEV1 60 to 80 is predicted for moderate persistent. All right, guys. Most nosocomial pneumonias are caused by C gram-negative bacteria. All right. Again, it's a knowledge check question, page 378. You're going to look at nosocomial hospital-acquired and bacterial pneumonia. It differentiates it. So again, page 378, you're going to look at nosocomial bacterial pneumonia. All right, guys, excellent. Okay, which type of pharmacological treatment would you prescribe for your COPD patient in group A? So I'm actually going to accept 2 answers here because based on page 412, your treatment standards for your gold treatment standards for COPD and guidelines, they actually do say it's a long-acting bronchodilator. So bronchodilator or a long bronchodilator, if you got A or B, if you chose A or B, I'm going to give you the points for it. I'm going to probably do 2 or 3 other questions on a couple of the other quizzes that you guys kind of didn't get wrong, but you didn't pick the best answer, but you all consistently picked the next best answer. So I will go through that and give you guys some fetch points on that after this week. All right, so do expect a few extra points on your quizzes. So anyway, in terms of the type of pharmacological treatment, look at page 412. Again, this is a knowledge check. You want to go ahead and look at those treatment standards for the gold treatment standards for COPD. So that's group A. In group A, we are prescribing a bronchodilator. All right, and which of the following is a major risk factor for fatal asthma? Okay, again, looking at this question, major risk factor for fatal asthma. What is fatal asthma? Fatal asthma is death, right? It's literally asthma that's going to kill you. So when we look at these answers, which of these particular answers is something that could actually make your asthma want to kill you, or make your asthma so severe in terms of an exacerbation that it will actually kill you? So allergy to pet dander, we can throw that out immediately. That's not so severe. Exercising in cold weather can definitely exacerbate asthma, but will it make it so severe that it could kill the patient? Probably not. Smoking and vaping definitely could be a risk factor. Would it be fatal? Well, it depends, on the patient. We need more information about that. But more importantly, C, hospital admission in the past year, very, very big risk factor. Why? Because this patient is already immunocompromised now that they've been in the hospital in the past year. Guess what? They were pumped up with steroids. They were pumped up with antibiotics. They were pumped up with treatments. You don't know, and also on top of that, they were exposed to nosocomial infections while they were in the hospital. Being hospitalized with asthma does not, and then getting better, that's great, but they're not actually, their body is not stronger because of it. They are actually now more weak than they were before because their body just went through a lot of fighting with a lot of steroids and a lot of medication that most likely weaken their immune system. So if your patient is asthmatic and they're starting to have an exacerbation and you already know they've been admitted in the last year, the likelihood is your patient is going to get bad very quickly. You're going to want to consider hospitalization for this patient if they're starting to decline, because they will decline very quickly. Again, look at your risk factors for fatal asthma, page 406, box 31.3. All right, make sure you review that, guys. All right, so your study guide is posted. This is just basically a copy of it. I just copy and pasted it. Go ahead and print your study guide, this is the outline, actually, I should say, the study guide outline. Go ahead and print your outline, create your study guide, and really, I would focus on these particular things that I listed. I hope this was helpful, guys. Again, look at your billing and coding quiz. Definitely review that. for more extra review. And make sure you're looking at these particular tables and pages that I mentioned with the answers of your quizzes. All right, guys, have a great week. Happy studying. If you have any questions or you'd like to meet with me, please feel free to email me. All right, guys, thank you.